We're going to get started. Welcome back to our Keeping Kids Safe series. We were so inspired by last week's discussion on building resilient kids and communities. We loved hearing from Headquarters Counseling Center, our own panel, and especially from you all. Once again, you guys did such a great job in the discussion box of giving comments and resources to each other and sharing your ideas. And so we just want you to continue that this time because we love that it's really a collaborative community when you guys are participating in that way. So today we're going to learn more about what happens during hospitalization and identify ways that we can support families before, during, and after an inpatient stay. In addition, we're going to hear from Southeast Kansas Community Health Center and learn about the innovative things that they are doing to keep kids safe. So before we begin, I just wanted to review some important tips. Again, that we know this is a collaborative learning community, so please turn on your cameras so it feels like a community. We also ask you that if you haven't already, put your name and the city that you're from in your title box so we can see it. And then again, please continue to use the chat box to share any questions, comments, and resources, and we'll try to get to all of those today. We want to encourage people to share questions and cases, but it's important to maintain confidentiality. We're bound by HIPAA, and many of you are bound by FERPA. Today it's going to be even more important because we're sharing a real case from one of our real community agencies, and so it's going to be de-identified, of course, but we just want to make sure that we really respect that confidentiality. After each session, you will be sent the presentation slides, a link to the recorded video of our presentation, and an evaluation link. And it's extremely important that you fill out that evaluation link so that you get credit for being here, so you can get CME credit, and also so we can get feedback and continue to get better. And so we can share that feedback with our funders so that we can continue to provide these at no cost to you. Lastly, I want to emphasize that this, again, we've talked about this before, but this training is really just for educational purposes. And we're not set up to provide clinical services here. So we know this can be a really distressing topic. And so we'll have some staff staying a few minutes extra in case people need to debrief or talk more. But we'll also send out resources and contact information for your local community mental health centers. And please feel free to reach out to them. They're always there to support if you need it. And of course, if you or someone you know is thinking about suicide, please call the National Suicide Hotline at 1-800-273-TALK. And if there's an urgent threat, go to your local emergency room. So let's get started with some introductions. We have a great panel for you today. While we're introducing our panel, please respond in your chat box by telling us in 10 words or less, what questions do you have for our panel about hospitalization, just so we can make sure that we're kind of trying to get to some of those today. And also, what information do you need that would be helpful for you that you could share with children and families about hospitalization? So kind of just what your hopes are and questions are for today. So again, I'm Skylar Bellinger. I'm a psychologist here at KU in pediatrics. So
I'm Emily Snow, and I'm the Director of Behavioral Health and Psychiatry Operations for the University of Kansas Health System.
And I'm Mitchell Douglas, Dr. Douglas. So I'm a psychiatrist and a child psychiatrist, also training in pediatrics. And I'm the medical director for the University of Kansas Hospital Marillac campus, which is KU's 68-bed inpatient child psych hospital. And should I take it away?
You want to do anybody else?
Keep going?
Yeah.
Are we going around? I don't know what we're doing. Yeah.
I'm Alice John. Again, I'm the postdoc fellow with this project, and my specialty is in applied behavioral analysis.
Chandra Gordon, I'm a social worker working on the project.
I'm Michelle Utt, the program manager for Telehealth Rocks.
Sharon Crane, I'm a child psychiatrist here at KU Medical Center.
Evelyn Nelson, I'm a psychologist here at KU Pediatrics.
And is Julie on yet? Have we seen her on yet? From Community Health Center?
Hi guys, sorry we had some technical difficulties. I am here, I'm the pediatric care coordinator. I have Carissa Castillo and also Kristen Simmons here with me. There are behavioral health coordinators, consultants, sorry.
No problem. Wonderful. Well, as you guys can see, we have a great group for you today. So we're gonna hear from all of them, and yeah.
Yeah.
Oh, we have some questions, I think.
We do have several questions from
or just
chat in general. Just criteria for release from hospitalization, criteria for referrals and discharge.
Okay.
How are we going about communicating with schools? The other questions are ideas to help students re-enter school post-hospitalization, thinking about accommodations and ways to prep teachers, how to support the families. And then also there was a question regarding what does hospitalization look like and what can they expect?
Wonderful. Hopefully we'll get to most of those, but also Dr. Douglas is over here like trying to write these all down, but we'll review these with you. So you don't have to remember them all now. But
get some sense of where we're going to take this.
Yes.
Okay.
We appreciate it.
So, and I have about 20 minutes. Is it possible, am I on?
Yeah, you are.
Okay, so talk that way. I'm Mr. Douglas, Dr. Douglas, Medical Director at KU Marillac. I do lots of presentations, but this is my first time doing a presentation to a small camera with not a live person to interact with. So I'm looking for feedback visually, and I'm not getting much except for a camera staring right back at me. I'm presuming there's someone out there. Or I'm not just insane and talking to.
Yep.
Okay.
Yes.
All right.
We have,
There are 7 people. Okay. Hi, guys. Again, I'm the director of an inpatient child psych hospital, University of Kansas Hospital Marillac campus, 68 beds, which makes a fairly large size facility. I've been at KU since 2015. I'm going to talk for 15 or 20 minutes and try to address some of these questions with the assistance or with the help of Ms. Snow to my right or left. Really focusing on just some basic stuff about when to think about hospitalization and how that process might work. I use the clicker. All right. So full disclosure, I don't have any financial relationships with anything to disclose. We're not going to be talking about medications during this presentation. We're not going to discuss the use of approved or unapproved investigative or commercial products. Okay. Next slide. Okay, so I'm Mitchell Douglas, Dr. Douglas. This is Emily Snow. Next slide. The information, okay. And so we're going to be talking about stuff in recommendations, which are, considered basic evidence and basically accepted within current clinical practice. What we're going to talk about. So we're going to talk about what is the basic process for how a child may or may not end up being assessed and then admitted to an inpatient psychiatric hospital. We have developed at KU Marillac a currently 16-bed, likely expanding to a larger capacity inpatient unit designed specifically for individuals who are at risk of suicide and is designed to help decrease that risk. It's a suicide prevention unit. We're going to look at some of the inclusion and exclusion criteria for this unit and talk overall about the risks and benefits of inpatient hospitalization. Okay, now it's our poll time. So poll, is that considered a poll or poll? We have 2 questions. Get ready, get your clickers ready. I don't know what you have, some sort of device out there. How familiar are you with hospitalization process for children and adolescents at risk of suicide or suicidal behavior? A through E. Just like a Likert scale. A, nothing, E, do it all the time. Oh, there's live data coming through?
That's not the right poll.
Yeah, I think that we're going to get the right poll up.
Oh.
We were asking about suicide screening, which is good too, but we've already talked about that one. So you can keep reading the questions and we'll put up the right one.
So you're familiar, so then, it's a real question. I'm kind of curious, like, if you see a child and I'm talking to people in a school setting or a clinic setting.
Different.
All of the above.
All the above. So whatever setting you're working at, if you see a child who's in acute danger to themselves or to others, and you're thinking that they may need inpatient child psychiatry hospitalization, do you have some familiarity with how that process might work? Ooh, live data? Look at this. Wow.
Right?
That's really cool. So it looks like over half are only not all familiar or slightly familiar. This is going to be a side question, but like, let me just ask this. Okay, I really like feedback from people, so this is driving me well. How many here are very nervous about that process?
You can type in your chat box.
Type in the chat box. Is this like the idea of trying to figure out, I got this kid in I'm a school counselor, and the child shows up and says, yeah, I'm planning on going home and completing suicide. Do you feel like you know what are some steps you could do in that time, in that event, or is that clear my schedule, let's figure out what the next step is?
We got one. So somebody said the liability is a big concern for our counselors.
Interesting. Okay.
That's true.
Yeah.
What else? Someone see that better than me.
Okay.
I've done many risk assessments and I feel I know the steps that are taught, but it's also, I've worked with some patients who have been SI, I think every time feels concerning.
Yes.
We have a protocol in place. As a case manager, I am unsure of what I am supposed to do other than take them to the ER or crisis.
Good start.
Serious with serious consequences and outcome.
Yes.
Good.
Okay.
Lots of good responses out
Yeah.
there.
Also, like half of the people said they have at least one option in their community or nearby community within
Okay.
1 hour driving distance for hospitalization.
Okay.
Oh, Brandon says lack of resources is a concern.
Yes.
Dora Schaefer also says that they feel nervous as we don't have access for children to be transferred to. And then Donna Glover says even knowing to go to the ER is a safe step.
It is a safe step.
That is.
Yep. Poll question number 2. Are you aware of any inpatient psychiatric hospitalization options for children and adolescents at risk of suicide or suicidal behavior in your community?
Yeah, they already shared.
And they already
their
did that one,
results.
and that's what we got. So at least everyone's like, yeah,
Good.
good. And I'm talking to individuals throughout the state of Kansas.
Mhm.
Okay, so West and over. Okay. All right. So talking about inpatient hospitalization. So, ACAP is the American Academy of Child and Adolescent Psychiatry. That's the sort of medical association that myself and Dr. Kame are members of. I want to be clear. ACAP endorses, and I agree 100%, children and adolescents should always be treated in the least restrictive setting appropriate to the individual clinical needs. So that means I have no desire to have a patient in a locked inpatient psychiatric hospital unless they need to be there for reasons of the safety of themselves or others. If they can be treated, and our ACAP principles lead us to this, if they can be treated in a less restrictive setting, we're going to push for that. And that's not just because we're running out of bed space or anything like that. It's that we know we have better outcomes. And it can be very traumatic to a child to be taken away from their familiar settings, placed in an unfamiliar environment, even a supportive but unfamiliar environment, unless it absolutely needs to happen. So we're going to always be pushing, does this child really need this level of care, or in sort of the spectrum of care between once a month therapy, once weekly therapy, IOP, partial hospitalization, inpatient hospitalization, where on that spectrum of care do they need to be? And so that's one way I'm sort of conceptualizing it. One of the hard things about inpatient psychiatric hospitalization is that the practice, and I go to the conferences and I sit with the board, or the group, the committee group for ACAP, and we discuss this. There is not an updated treatment parameter for the treatment of kids and adolescents in the inpatient center since 1989. So I can't, during this type of presentation, say, here is the 2017 revised parameters for what you should expect from an appropriate inpatient psychiatric hospitalization, because the current standards out are almost 30 years old. There's an ongoing discussion at ACAP to have this be revised, but right now, there is a 2010 recommendations for the treatment in a residential care facility, but one that's very different than acute psychiatric hospital. So that leads us for based off of evidence for this area and what I consider to be current clinical practice. Other comments, questions coming up? Or who knows? Okay. But even with what's being stated with the residential care per ACAP, as well as if you look at like the Casey Foundation and others, the best place for children and adolescents is always going to be at home with their families. And I know we're going to talk about, doing inpatient hospitalization here in a moment, but I really want to make sure that's clear. That's what this is all about. We want to get people ready so that they're safe and can safely return to a less restrictive environment. Okay, and it's sort of statement ours. Why do patients end up in the hospital? And this gets really vague because you say, and I presume most people who are listening know the basic idea. Are you dangerous self or dangerous with others? But the problem is that's a very wide spectrum. What does dangerous self mean? Does that mean they might scratch themselves? Does that mean that they're planning on completing suicide with a handgun? So how do you, both of those can fit the idea of acute danger to self, but you are having to make that gradation, that discussion about what is the actual risk and what is your concern to make sure it does or does not warrant inpatient hospitalization. The similar idea of that being a spectrum is the idea of with danger to others. Is this a six-year-old child who says they might hit their brother? I would call it part of normal developmental behavior. Is this, again, looking at a 10-year-old who's talking about significant damage or violence with a firearm in a school setting? Whole different category. So trying to put this in categories is really part of what we're trying to do with our admissions process. We also have to be careful when we're talking, especially with the older adolescents. Generally, we're looking for these dangerous behaviors to be occurring in the context of psychiatric illness. So there are individuals who engage in dangerous behaviors or make verbal or physical threats that do not necessarily relate to a psychiatric illness. In that case, it's going through labeling or calling that behavior in terms of psychiatric illness or in terms of a legal issue needs to be discerned as well. And that's another thing that we're trying to sort out with our admissions process. So I can't give feedback.
They're actually answering each other's questions. Someone asked what's IOP and somebody said intensive outpatient
Oh, okay.
program.
Sorry.
So they do a great job.
I should not be using jargon. I'm sorry. Yeah. So one thing is I gotta watch my time, but I do want to take 2 seconds. The one thing I thought was helpful that ACAP does have, when you're talking with families about inpatient hospitalization, which can be a very scary process, they do have a very nice facts for families. Here's 11 questions to think about when you're thinking about inpatient hospitalization, which I'm going to use kind of guide my discussion with myself because this is one-sided discussion. So, when you're thinking about it, the family's going to ask you, why is this psychiatric inpatient treatment being recommended? How is it going to help? And really, that's a very valid question. So what is actually going to be the change in outcome that's going to occur for this patient being here as opposed to being intensive outpatient or a different environment? Is it, hopefully it should be, I'm really worried the child's going to significantly hurt themselves or others, and we need to be them in a contained space where they can be monitored 24/7 and not harm themselves. Are there other treatment alternatives though? Does it have to be this? If we don't look at inpatient hospitalization, what are the other options? And this, the next one, I do think it's reasonable to ask and consider when you're looking at hospital environment, who are the care providers? There are lots of great hospitals. I like the hospital I work at as well. I think Marillac does a great job. We are staffed with with board eligible child and adolescent psychiatrists. I would recommend that as a standard of care. The treatment of an 8-year-old or a young adolescent and trying to figure out the psychiatric illness is very different than treating an adult. And trying to find an individual with specialized care in the treatment of children, I think is very important. I think it's appropriate to ask, what does inpatient treatment include? What's going to happen? Are they going to sit there all day and watch TV, but make sure they're safe? Or are they going to actually engage in treatment? Who's doing the treatment? Do they have therapy? Do you have psychologists? How are we making sure if they're going to do meds? Who's prescribing the meds? Who's monitoring the meds? Who's doing your group therapies? What is treatment? So at Marillac, we were able to say, here's the schedule. If you go to the insights unit, 8 o'clock to 9 o'clock p.m. is pretty much scheduled down to the hour with what activities they're doing, what types of therapy, expressive therapy, whatnot they're engaging in. And you should be looking for that and what's going to happen. What's the role of the child and adolescent psychiatrist? Number 6, it is a reasonable question. Who's going to pay for this? How much is it going to cost? And it's because I think a lot of times families do get concerned with, child's going to be hospitalized, it might be 4 or 5 days. If the family doesn't have financial means or doesn't have insurance, who's going to pay for this? And whether if it is not paid for, will the hospital system or some other entity be able to help with that process? That's the same with number 7. I think it is appropriate to ask when you're looking at the facility, depending on the age of the child, what type of unit will they be on? Are they be on unit designated by disease state, as in this is for individuals with depression and suicidation? Is this going to be a place by age, so that all the kids under age 12 will be over here, 12 to 17 over there? Different hospital systems have different ways of doing it. Lots of different ways of dividing it. But the parent or whoever's referring should have some idea of oh, I'm setting a 14-year-old over there. Are they going to be in a tween unit? Are they going to be with older adolescents? Are they going to be with younger? Or do they take them all and stick them all together? In which case, you could have some concerns if the type of programming for an 8-year-old versus a 13-year-old probably should be distinct and different because those clinical needs are very different. What's the discharge plan? What's the involvement with the family, and what should the family expect during the hospitalization? I think those are relevant, great questions to always ask. For Marillac, we're expecting that the therapist should be in direct contact with the family every day and should have ongoing, pretty close contact with the treating child and adolescent psychiatrist. What's the plan upon follow-up? So those are some things to be thinking about. I'm watching my time. And so I know Marillac, we're a 68-bed inpatient child and adolescent psychiatric hospital. So all we have is kids. So we see kids as young as they come, up to 17 years and 364 days. When they turn 18, that's an adult, and we consider that adult. We divide things by age. So we have units for younger kids, we have units for older kids, We're looking at developing some further specialized units in the future. As of September 6th, we did start Insights, and so that's our suicide prevention unit. I'm going to hand it over to Emily to talk a little bit more about that unit and how it's run.
So the Insights unit is a new specialty unit at the Marillac campus for the University of Kansas Health System. It is currently a 16-bed unit. We'll be expanding to a 24-bed unit actually on Monday. And we have distinctive admission criteria in addition to the inpatient criteria that we have for admission into our hospital in general. It's a comprehensive 5-day program. As Dr. Douglas inferred, it's very rigorously scheduled, and we do mindfulness and expressive therapy, group therapy, individual and family therapy, but their schedule is very well set and very rigorous. The goal is to reduce further suicide risk and to reduce hospital readmissions. And the care team includes child and adolescent psychiatrists, master's level therapists, and doctorate level psychologists, as well as nurses and expressive therapists. We offer, actually to all of our patients, we offer expressive therapy, which includes drama, music, art, and recreation therapy, which are really integral to the care that we provide at the Marillac campus. We also can do psychological testing as needed and as indicated by the physicians, which can be very helpful for families who can't get psychological testing when their children are at home. It can help them get services at school or guide care after they leave.
We had a quick question from about how many beds are usually full. Have they been totally full in the Insight program?
They have been consistently full, and that's
Okay.
why we're opening more
Okay.
next week. We're rearranging our units to be able to open more next week.
And also Donna says, I love the expressive therapy. So-
we love the expressive therapy as well.
And
It's
then-
pretty amazing.
And then another question from Megan is, what is the biggest difference between this program and typical hospitalization then?
This program does some very specific work. Well, one thing, let me back up a little bit. One thing is the inclusionary criteria and the exclusionary criteria. We require that patients who go to Insights are between the ages of 12 to 17. They have to meet the criteria for inpatient hospitalization, and we have an acute concern for suicidal behavior. Many of our patients are coming straight from emergency rooms or other hospitals and have attempted suicide. The rest of them are actively suicidal, have a plan, have ideation and intent. And so that's part of the requirement for the program. They are primarily diagnosed with depression, affective or anxiety disorder. And the other piece is they have to have the cognitive ability to engage in some comprehensive individual and group therapy, because we do have a pretty intense schedule for them. The other piece is that they have to remain safe around other individuals and other patients with good supervision. So that being said, patients who are not appropriate for the Insights unit would be those who are currently exhibiting psychosis that could inhibit their ability to participate in any type of curriculum or therapy, those who are exhibiting physical aggression or have a history of assault or assaultive behaviors, and those who've been diagnosed with intellectual developmental disabilities and autism. That group of patients probably wouldn't benefit from the intense groups and the intensity of what we do on the unit. The unit has a curriculum that we've named Reset. It was designed by it's backwards, sorry. It's been designed by our clinical team, and it is based on both dialectical behavioral therapy and cognitive behavioral therapy. And so we have a 5-day program, and each day is devoted to a different component of the Reset program. So we look at relationships, interpersonal effectiveness, emotional regulation, self, energize, and tomorrow. So we look at distress tolerance, different parts of the dialectical behavioral therapy curriculum practice and cognitive behavioral therapy. We also, throughout the hospital, implement trauma systems therapy, which works with kiddos who have been exposed to trauma, and 91% of our patients that are admitted to our hospital have had at least one trauma. We collect data on ACEs, so that is important. Excuse me. And that is really what the Insights unit looks like. It's been very successful. What we've seen in just the past month is a reduction in seclusions and assaults throughout the entire hospital rather than just on the Insights unit. And so what we're seeing is that the separation of these patients and the different programming has improved the ability for us to treat our patients in a calmer environment for everyone, not just the Insights patients. And so we're very excited about that and the potential for that.
And I know we're pushing time because it's 12:25.
I think you're okay. We have until 12:35 with some questions. But we want to leave some time for some
And
questions.
I think it might be helpful for Emily and I to have 2 seconds. Well, because I don't feel like we really walk people through the, yeah,
Okay.
we kind of walk through the process of, like, let's say I'm a school counselor, the child walks in and has been identified as having suicidation. You talk, you're like, yes, they have an acute risk of, they're like, oh my goodness, I haven't done anything to harm myself, but I really can't stop thinking about completing suicide when I get home. What would you want the school counselor to do?
Well, it's really important to know that our hospital, as well as most hospitals, offer free assessments. And so we will assess any child to determine if they meet criteria for hospitalization. And if they don't, we'll still safety plan with that family and refer them out to other resources. And we also do a wellness check with the family. But anybody can refer a family to us. We just ask that you make sure they know that it's an assessment for inpatient hospitalization and not for outpatient services at this time. So that's really important. We work very closely with schools throughout the state. And one thing that I would bring up, that because you brought up school a couple times, is that it's really important to work with the families to either have them sign a release for you to speak to us or have a release signed for us to speak to the school. That's been a frustration that we've had with the different school systems, so that we can help prepare the child while they're in the hospital and prepare for them to return to the school environment, because they'll need help knowing what to say about where they've been, why they were gone, and who they want to know. And the school wants to support kids, but if we can't tell them anything about them being in the hospital,
And we legally can't unless we have that ROI on file.
So do you have them sign it when they get there, or do
we
you
try,
think
but
We also need the
we've
encouragement.
seen that it's better if the school can get the release. We've seen better results with that, just because the school has already talked to the family and sent the family over to us, and then we're a different big entity. So we've seen that that has been more successful. We also work with the kiddos and prepare them. We do preparation about what they're going to do when they discharge. And we also give a copy of this, an extra copy of the safety plan and a release of information to the family in case they want to share that with the school. So that's, I know, is a question that is asked frequently by many people.
Mm-hmm.
And some folks are saying that that's a frustration on the schools end too. Brenna's saying that that sometimes the parents aren't comfortable with that. So maybe even just hitting it kind of at multiple times of like how important it is from both ends.
And really, I think that has lots to do with destigmatizing as well. I think we've seen, I've seen some cases where the family wants to hope that this hospitalization will, great, we've done the Insights program, we've done the hospitalization, we may or may have not started medication, everything's fine now. I'm like, no, we're going to need lots of support. So when we're dealing with, say, if it's major depressive disorder, recurrent, we're going to make things stable, but they're going to need ongoing treatment and support, and they're going to need to engage with all the supports they have available, including the school. And that sometimes is a hard message for the family.
I like to, I kind of refer to us as the emergency room for mental health. And even though you don't stay in an emergency room generally, our short stay is just, it's an emergency stabilization for preparing for long-term recovery and long-term mental wellness.
Yes.
There's a question too from Megan. She said, how often or what percentage of students are denied or referred to outpatient instead of being admitted?
About 6%.
6%
are not admitted.
Oh.
So our admission criteria is, our admission percentage is pretty high. Because by and large, if you start thinking about, by the time they've often gone, most of our patients are being referred by another entity. If they're coming from an outside ER, that's going to be a direct admission. If they're going through seeing a school counselor, discuss the risk and concerns, driven in, there's going to be concern. And that we're going to be very hesitant to be like, no, I think we're going to be okay on that. Now we still assess. Yeah.
There's also some good comments about HIPAA versus FERPA and releases. So that would be something I don't think we can solve today, but
No.
maybe even like put brainstorming, like, is there something that was sort of double as both? People are even mentioning maybe putting on like something automatic that's part of the intake process. But
Yeah.
I'm actually reaching out to another organization in Wichita who provides mental health services that communicates with the school to see how they get the release or how it works, to see if we can implement that and share that with other hospitals as well.
Yeah, that's great. And then I do think walking through that process. So they get there, I think that would help. Like,
Well,
what
one thing
then
I sort of set up
happens?
is, so parents there, the school counselor sees the need. You know, one of the problems or challenges I would think, so if you're like, oh, what do you do? So certainly contacting the family or whoever the legal guardian is. One point where a decision has to be made is, what is your method of transfer? And I think that's really something you want to think about. So if there is an acute concern for safety, how is that patient or individual being transported from even the school counselor's office to the next place? And is that going to be direct to an emergency room for further emergency stabilization, or is that driving to a hospital? And that's a big decision. If you're telling a patient's acutely suicidal, being in a vehicle moving at 65 miles an hour, yes, you have door locks, but one button away. So you need to then look at, no, this needs to be either an ambulance situation direct to the emergency room stabilization. Is this a family transport to the closer ER than the longer distance hospital? Or are you considering having the patient transfer directly to call whichever inpatient hospital you're looking at and scheduling an evaluation for admission? And that's part of that, trying to figure out safety. And those are things that you're trying to figure out. Talking to an admissions team in a different facility like Marillac could be of some help. I'll guide you through that. But really making sure that process transfer from one end to the other, after you finally have that disclosure of suicidation, that's a high risk time period.
And then once they get there, it's like, so they get a screened in, and then it's like, what
So
does
the
it
patient,
look
so
like
once
if
they walk
weren't
in,
inside?
so they're there, they're going to be seen by an admission staff. So it's going to be a master's level therapist who's going to spend upwards of 60, 90
Between
minutes.
45 minutes and 90 minutes with the family.
With the patient and the family, trying to figure out what's happening from a clinical standpoint. Then that patient's case is going to be reviewed with the attending physician.
We also do medical clearance.
And we also do medical clearance before they even walk in the door. So as soon as they walk in the door, seen by a nurse, make sure there's no acute medical concerns, the disclosure of a recent overdose, lacerations, cuts. Those are the most simple things we're concerned about. Check vitals, make sure we're stable. Admissions assessment, 45 minutes to 90 minutes. Then discuss with the attending psychiatrist to make a determination to meet or does not meet criteria for admission. Take from there.
No, and then at that point, the patient says goodbye to their parent, and the patient will meet with the nurse, and the nurse may meet with the parent to gather more medical information, and the patient is brought onto the unit after that, after the meeting with the nurse, and the staff orients the patient to the unit, assigns a bedroom, and they begin. It depends on the time of day, what's going on. Usually there's a group going on, or they're seeing doctors or doing games or recreation therapy. But and go ahead.
They're going to be, so make sure they go. So they are going to change their clothes. They're wearing
We
basically supply clothes. It's sort of sweats. It's not fancy, but we changed that policy a couple of years ago, and it seemed to be very actually helpful. Allows for a little bit of anonymity, also less sort of stratification of individuals. Also, from a safety standpoint, significantly decrease our concern that anyone is bringing anything into the hospital which shouldn't be in the hospital, like something that they could harm themselves with. Generally can be seen by the child minimum 24 hours or maximum 24 hours. Most patients are going to be seen really within 8 to 12 hours by the inpatient child analysis psychiatrist. So they show up before 12, they're going to be seen within hours. If we usually we don't have 24/7 physician staffing, but basically 12 hours a day we have a physician on site. So if they're showing up at 3 in the morning, it'll probably be the next morning. If they show up during the daytime hours, they're going to be seen, staffed, and you should expect a phone call. The parents should expect a phone call from the psychiatrist later that day. So that's the timing you should expect.
So they're checking in, it's mostly that medication management, but then they're also participating in some of those activities
they
that
do
you talked about
every day. All patients do expressive therapy, individual or family therapy, group behavioral therapy with a master's level therapist. And then we have a lot of psychosocial groups that are run by the staff on the unit that work on different aspects of development
Yep.
and behavior.
We do have a full pediatric team. We have a full-time pediatrician as well as 2 other full-time members of the pediatric team, a nurse practitioner and a PA, which enhances our ability to take care of medically complicated individuals. So that's something we're very proud of. And certainly we are KU, so being a KU facility, if there are people who need higher levels of care on the pediatric side, we coordinate closely with our pediatric service and figure out what they need.
So there's a lot of conversation on the chat in regards to the ability to find care in more rural Kansas with a lot of the hospitals closing. So I guess in one way I would sum up some of the questions is what happens when there's no availability? What are options for families in these communities? So one, I mean, there's been a lot of communication regarding the KVC hospital in Hayes having closed their inpatient, and there's 5 to 6 hours to a closer facility that may not have beds.
So Wichita has opened, KVC Wichita has opened, and they're a 52-bed inpatient facility.
Child or mixed? Just child?
Inpatient child facility. And so they have expanded in order to meet the needs of some of the rural communities. There is also a facility in Nevada, Missouri called Heartland Behavioral Health, who helps serve Southeast Kansas along with us. We serve them as well. But those are 2 of the more rural facilities that serve patients. If you come through our doors, we are going to figure out how to help your family. We are not going to send you away if your child meets criteria. We will figure it out.
And our catchment areas, if you know, the
6
catchment areas,
states.
this is not occasional rare event that a person's coming from 2, 3, 4, or 5 hours away. So both Kansas side and very often on the Missouri side and other states as well, we are used to seeing patients coming in from a specific distance away, coordinating with those, coordinating with those outside hospitals and such about what to do next.
People are saying that you guys need to open a Western outpost.
Which actually, one of my therapists asked if we could do that today. They asked if we could open in Hayes, since we are affiliated with the hospital in Hayes.
There really does seem like a need.
I know there
I
is.
didn't realize there's really. So if you're on more the western side,
It's either Colorado or Wichita.
And Wichita's pretty far from.
Yeah.
Yeah, that's just, we definitely, sounds like we need to have a bigger conversation about figuring out resources, and that's, but I do think there's a lot of people that are invested in that, and it seems like, really
We are
wanting
very
to
invested
meet
in it.
kids where they're at and support them. There's some good comments coming through. I want to get to Southeast Kansas Community Mental Health or Community Health Center. So the hospital school liaison I want to share with you, Emily, in Wichita, communicates with USD 259, and she said she works on the admission staff at Via Christi Behavioral Health, and she works with them and parents to get the FERPA and ROI in order to work with Wichita schools. So maybe that's someone that's kind of Melinda's job, is to try to figure that out.
Great.
So I think that was a question too, is that follow-up, and it sounds like some of the breakdown is we don't even have permission to do some of the follow-up that we want to do. Right.
That is correct.
So maybe we could all have better follow-up if we had more of that permission.
Helping the family know if the child's going to go in, it's going to be in inpatient hospitalization as well for around 5 days. Continuing, if the school has a relationship with the family, knowing, and we try to work as soon as they hit the doors, we know that they're going to discharge. We're not a long-term care facility. We're averaging stay of 5. We keep kids as long as we feel that they need to be there. As long as they're safe, we're going to get it going. But as soon as they hit the door, there needs to be an active intent to try to figure out what the follow-up is going to be, as opposed to waiting till they leave, even though they had the paper saying, please follow up. There's a scarcity of resources. And I suspect, I don't work in the Western Kansas, but I suspect there's a scarcity of, psychiatric support in Western Kansas. So if you know it's going to be coming, get that appointment on the books.
So what does their follow-up plan look like from you? Is it like I know they're supposed to have like a appointment with somebody?
So they're supposed to see someone within 7 days. We do struggle, in the past 2 years, we've struggled because a lot of providers won't let us make an appointment. And so we have to provide multiple resources to the family and follow up with the family to make that appointment themselves. So that has also been a barrier.
Let us call up and say,
would be nice if you could do
John,
that.
X patient is here. Please make an appointment for next week.
Correct.
It's not allowed.
And they don't let us do that. And we continue to work with the insurance companies to try to improve that and work with the families and with some of the larger providers as well to do that. We are pretty lucky that we have an outpatient office at the main hospital, and we can utilize them for local patients, but it's a little harder when they're further away.
Yeah, I'll put a pitch out there. If there are any pediatricians or people working in a pediatric facility, you know, if you feel comfortable seeing a patient with a primary psychiatric diagnosis but need a little bit of help or support, it is appropriate to try to call KU. There's an on-call KU, adolescent psychiatrist on 24/7. If you're seeing a kid discharging from Marillac, but you need a little help with how to dose a psychotropic medication, call. That's part of it. If you can help us on the pediatric side, making sure these kids with psychiatric needs get those needs met, those meds refilled, or doses changed appropriately, we're happy to help.
I love that, and I love the idea of being creative. Like, I think that it sounds like from what we're hearing, we're just going to have to be creative about who can see the child and what kind of,
someone laying eyes on that kid.
And we see the goals that you're wanting to follow up on. So, I mean, even a school counselor or someone just that doesn't know them from the community mental health center could sit down and say, hey, how are you doing on this goal? Or, I think that would be.
Are you safe?
Yeah. Yes. So I do want to transition over. This was a really great conversation that I kind of want to continue because I just feel like there's so much kind of exciting things we could all do together if we work together on this. So, but let's move on to Community Health Center of Southeast Kansas and hear from them. You there, Julie? They were earlier.
Okay, can you hear us okay? Hi. Okay, sorry. We had more technical difficulties, so we had to change rooms. So I do apologize for that. We want to talk to you about an innovative model that we have tried out over the past few years, and I think we have it pretty streamlined now. So basically what we're doing is an integrative model of care, and that includes both behavioral health and dental care within the primary care setting. Where we're using that specifically is in the pediatric clinic. So each child who is ages 5 and above gets pre-screened at every visit, including acute visits. They get a depression screening. So if that depression screening comes back positive, then we can go in and grab one of our BHC specialists, and then they get to hop in the room and coordinate with the providers and the families and talk about interventions of care. And then I'll let them talk about more about what they do within that exam room.
So when the depression screen score is high, we first go in and assess for safety to see if safety is a concern and if that's something that we'll be addressing that day. If it's not, if the kid is just experiencing high levels of depression or anxiety or just moderate levels, we usually explore healthy coping strategies, self-soothing, coping activities. We've been using some bilateral interventions and some polyvagal interventions to help with the coping strategies in the exam room recently, and a lot of the patients have really taken off with that.
Can you describe that a little bit more? Some of us aren't familiar.
Polyvagal is the part of your nervous system that processes your emotions. And so there's 3 levels of it. The dorsal, the top one where you're calm state, your body kind of feels good, is called the ventral vagal state. And so that's really what we want our patients to feel.
Okay. We understand that.
I thought you were doing vagal nerve system stimulation there.
Me too.
Yeah, and then there's the sympathetic, and that's kind of like the flight or flight, anxiety, mix of emotions, and then there's the dorsal, and that's where kind of like the Eeyore depression is. And so the flow between the different parts of your nervous system through your emotions is supposed to be pretty fluid, but we notice that a lot of patients get stuck in the sympathetic and the dorsal, and so we help them by identifying anchors that will pull them back up to the ventral. And so anchor is something that has such a positive effect on you that anytime you think about it, your affect will literally change. You'll either see the person completely become relaxed, or they'll start laughing and giggling. For kids, sometimes an image is not enough, so we actually give them something visual, like a funny cat video or something like that, and we start there, and then we build off of that. So that's how we're using the polyvagal. The bilateral stimulation is just helping them realize what type of activities they may already be doing that's bilateral, because if you engage in bilateral stimulation for at least 60 seconds, it'll help shift you out of your amygdala and into your frontal lobe. Your frontal lobe is where you can actually begin to problem solve. When you're in your amygdala, you're like just feeling really emotionally dysregulated and in like fight or fight response. And so you can't hear really anything anybody's saying to you when you're there. And so if we walk into a room and somebody's in that state, it doesn't do anything we say, they're not going to absorb in. So some basic things is like sometimes we take them for a walk to get a drink of water or something, because walking is a very natural bilateral way to stimulate. Sometimes we'll do some like tapping, like finger tapping or toe tapping. Sometimes I'll blow up a glove or a balloon and we'll just like tap it back and forth, and I'll have them use their hand. Tap it with this hand, I'll tap it with this hand. But they feel like what they're doing is a game, but then once we get them into a state of mind where they're actually able to think a little bit more logically, then we begin our intervention. We try to avoid hospital at all costs because it's a disruption to their lives. And also, you know, with psychiatric hospitals, it's not like a physical hospital where your parent gets to go and stay with you the whole time. We definitely see the value in the hospitalization because sometimes it's really needed. But if we can come up with a valid, secure plan of safety, then we develop that plan of safety, and then we check in with the parent each day to see how it's going, whether or not we need to meet with the patient daily until they are out of the crisis. We need to tweak the plan, and ultimately, like if things continue to get worse instead of better, then we look at hospitalization.
I like that hierarchy of support, especially talking about kind of that lack of resources in some of these areas, you know, that it's better if we can kind of figure out different ways to support in this. I like, and also the checking in really frequently to make sure that we don't get to that really unsafe place where they might need an inpatient
That's
hospital.
the bonus we have, is that we have the flexibility and schedule on our unit that we have priority spots for urgent patients. And so if you're urgent, you can be seen same day. If you're coming out of the hospital, you can be seen same day. We drop those people right into the schedule. We don't turn them away. And so having that luxury when a lot of places are not, I've worked tons of places that I didn't have that luxury. Really helps us to keep our patients, you know, supported and wrapped with what they need to be successful. Now sometimes they will reach us and it's reached a point, you know, like that we can't plan for safety, but that's usually when it's already at the point that they have attempted. Or sometimes it's like a psychotic reaction, but we also have another thing that a lot of people don't have access to. We have psych providers, and since we're integrated care, we can sometimes bump somebody in same day to see a psychiatric provider and have their meds adjusted. That's unheard of in most places. And so when I used to work at mental health centers, sometimes if you needed meds adjusted in order to stabilize, they had to go to the hospital for that to happen, because you couldn't get into a psych provider for 2 weeks, even if it was urgent. And so that's something that we have at our disposal, doing integrated care, that really benefits.
I was going to say, you feel like the integrated care piece sort of allows for more of that kind of,
it does,
like faster sort of response, and then also that really immediate follow-up as well.
It does, because we work very closely with our pediatricians and family practitioners. And so like they trust us, we trust them. And So like if we can't get them into our psychiatric provider, we can go to our pediatrician or family practitioner and be like, this is what we're seeing. Would you be willing to come in and meet with the patient for just a moment and like see if you'd be comfortable trying like a antidepressant or, you know, something for sleep. Sometimes they'll prescribe some clonidine or something because the kid's not getting quality sleep and it's just kind of spiraling out of control. And so like having access to being able to start a medication same day is a big benefit, because that's something that a lot of times will lead a kid to the hospital is their meds, you know, aren't right and they can't get in quick enough to have it adjusted and monitored. But we monitor it after they prescribe that med. We will check in with the family and make sure it's going okay, and then bring them back in to see the provider if it's not. And so that's the flexibility of integrated care.
And when we say that we're integrated, we really are. So like their offices are in the pediatric unit.
Yeah, we're right there on the nurses station.
Yeah, so we all live and coexist together. And so everybody kind of knows what's going on with each patient that walks in the door that day. And we keep each other very, very well informed.
Yep.
So having all of that there just makes a huge difference, because you know, you don't have to walk across the building to find somebody, and it's
well, and that in the moment consultation, which is kind of what we heard from Dr. Douglas a little bit, like, you know, being able to, even if it's not a child psychiatrist, like if the pediatrician is willing to consult with him or with another, you know, specialist. So I'm almost seeing like a different echo arise of helping train some primary care places, and this model that you're talking about, but also, you know, having some child psychiatrists talk with those folks about, you know, how to manage that or how to feel more comfortable managing that when you do have somebody that's coming out of the hospital, how to check in on those types of things.
Absolutely.
Yeah, I think that would be good. I actually, you know, I've been in the field for quite a few years, and I did mostly mental health centers, and I mostly worked on crisis teams where I did the screening, you know, and where I was in certain areas, I worked at 3 different mental health centers in my career. We just didn't have the resources. And so sometimes kids would get screened into the hospital just because we could come up with a safety plan, but we couldn't provide the resources needed in the safety plan in order for it to be effective. And so through our integrated care model here, we're able to come up with solid safety plans. And so we feel safe letting them walk out because we have prepared the parent to be their shadow, and you know, for the duration of the crisis, and we're the parent's support. We're checking in with them, making sure that they feel like they can handle it. Do we need to come back in and do we need to address anything that's happened since the last time we've seen them? And so we stay pretty closely with them for the duration of the crisis. It's about 24-hour check-in, and we always direct to the ER if something happens in the middle of the night.
The other advantage that we have is we have school-based health centers. So we have school nurses and school therapists who work with us. So we can always, you know, make a phone call and say, hey, can you check in on this kiddo and see how they're doing, without letting the entire school know what's going on at that point. Just so somebody's there, and just keep an eye on things and watch out for any dangerous behaviors and that type of thing.
It's really like a wraparound.
Yeah, it allows us to wrap around. Yeah.
Thank you so much for sharing that model. I feel like, again, we could have a whole series on something like this, so maybe it's just like the tip of the iceberg, but there's been some good people like sharing some good things with each other. I did want to, Holly, who I just realized I've been talking to via email, and now I think she's the one on this echo, but she's sharing that in January, physicians will be able to call the KS Kids Map, which I know she's working on really hard to, for case consultation with Dr. Brown, a psychiatrist, and Dr. Klaus, Nicole Klaus, a psychologist at KUMC Wichita. So there'll be that. And and they're also, I know they're working on a list of like all like different therapists and things all over Kansas, so that when folks come in, there's going to be a centralized place to be able to identify where they can go for support. So they're doing really great work in Wichita on that. So that's really exciting. So Polly, thank you for sharing that. I don't know, it sounds like maybe there's not a phone number right now for that yet, but maybe maybe she'll send that out or send it to us and we can send it out when it's completed. Also, people were mentioning pursuing the SED or HCBS waivers following hospital discharge in order to get more services, which is a great idea. Oh, so Polly says they have a phone number, but they can't release it yet. So they will get that once it's up and running. They'll let us know.
Great.
Were there other questions you guys were writing down quickly as they came through? Oh, the one question was about like follow up and like, is there a, are you tracking that? Like, is somebody, yeah, how is that tracked once they leave?
We call the families and we track if they've attended their 7-day appointment, and if they hadn't, why not, and pieces like that. We need to expand our services to outpatient services so that we can better serve those families and track them. But we do track and do a warm phone call after they've discharged.
There was also some really specific questions I don't think we'll know. And I guess I don't know if there's a really good answer to this, but what if if you know the hospital in your area is turning kids away? Any ideas about that?
Well, I mean, every hospital is going to hate that I'm going to tell this story, but there are laws about EMTALA that require that if someone shows up at your doorstep, you legally have to assess and refer or treat the patient. So while I don't suggest you utilize that, if you're desperate, you need to take care of your child, and we as hospitals need to make you safe, because we want to save lives. We don't want someone out without resources.
And again, I think just thinking through that hierarchy of how can we sort of make that wraparound care on the first level, be able to create those safety plans and follow up really regularly, but then also knowing what your rights are if you need to go to the hospital. And then, so I think that's something that I've heard before is, sometimes you guys will say, we don't have a bed for a week or two. Is that something that
doesn't happen anymore?
Okay.
I will tell you that. That does not happen anymore.
And I would push, that's also
12
something.
to 20 hours.
Yeah. And so that's something too where we need to work on from our standpoint, but just because we're full, we have a lot, with a 68-bed hospital, average length of stay, 5-ish days, 4.2 actually, to be more exact. Like, there's lots of turnover at that volume. So just because an ER or whichever environment calls at 8 a.m. and we're like full, if you call at 12, it could be a different result.
Correct.
So it's worth saying, oh, okay, full now, re-inquiring at a later time.
It's very different now that we've expanded.
Oh, okay. Okay.
Yeah. And we're set.
So that's good to know that there's very rare that it would be a long-term, if it was truly necessary.
Absolutely.
No.
Because we discharge between probably 10 and 15 patients a day. So that's 10 to 15 openings a day.
Okay. One other question that I did want to get to before we wrap up is people were talking about telephone or telehealth intakes. That was, I think, an idea that came up. Is that something that you've done ever, the assessments over telehealth or over the phone, so they don't have to come all the way
Not
in?
outside the KU system.
Okay.
Within the system, yeah.
Okay. Well, maybe something to think about. I don't know, but not now.
Something to talk about for sure.
Okay. Wonderful. Well, this was a really great conversation. We really appreciate everybody joining us today and all of our wonderful presenters. Please join us next week, which will be our last week, so unfortunately, when we talk about supporting survivors. So Dr. Steve Lawson is going to come and talk to us about how to support survivors. We're also going to hear from a really great organization called Lock It for Love, and it's, I think, for a grandparent developed group. And they have really wonderful resources to share, and also they will partner with police departments to provide kind of gun safety and just safety in general, to kind of set up some safe environments for kids or kids that we might be concerned about, so that we can really keep them safe. So we will talk more about that. Before you sign off, please share in the chat box one way you will try to support kids and families before, during, or after hospitalization, after participating in this conversation. And each week we're going to try to share your comments with the group so that we can continue to learn from each other. So if you could just chat in the next minute or so, kind of one takeaway that you'd want to take away from today, that would be great. And otherwise, don't know if anything's gonna come in. We might not have quite enough time to review it, but
How about you to that?
no, it's coming through.